Good morning, everyone. Today I'll be presenting a case of ocular steroid-induced Cushing's syndrome in a baby. So it's a story of a 6-week-old boy who presented to pediatric glaucoma unit with a bilateral watering, photophobia, and ophthalmos in both the eyes. Family history was not significant. On examination, we noted that bilateral cornea was cloudy. Right eye looked more cloudier than the left eye, and there was significant cupping in both the eyes. So a probable diagnosis of PCG was made and child was started on brinzolamide 1% eye drop and was scheduled for examination under anesthesia. When we took child for examination under anesthesia, we noted that there was bilateral corneal haze with presence of epithelial bedewing. Posterior embryotoxin was also present, and on gonioscopy, high iris insertion was noted. His IOP was 12 and 6 and cup disc ratio was 0.5 and 0.3 in right and left eye. So we made a diagnosis of both eye primary congenital glaucoma, and child underwent both eye goniotomy on the same day. The surgery was fine and it was totally uneventful. On post-operative day 1, child was fine. Cornea was clear. There was no hyphema, no discharge. Intraocular pressure on distal tonometry was normal in both the eyes. So he was started on beta-methasone eye drop 0.1% too early. Antibiotic and lubricant was also started. On next follow-up at 2 weeks post-operatively, the IOP was 12 and 14 off medication in both in right and left eye respectively. On eye care tonometer, cornea was clear bilaterally. There was no hyphema, no discharge. Sutures were intact with no suture infiltrate. So his steroid was decreased to 6 times and was advised to taper weekly later on. And antibiotic and lubricant was continued. And next follow-up was scheduled after 2 weeks. So at 1 month post-operatively, we were surprised to see that child has gained a lot of weight. There was moon phases, truncal obesity, hirsutism was also there, and child has developed Cushingoid habitus. However, from glaucoma point of view, he was fine. IOP was 10 and 12 on eye care off medication with bilaterally clear cornea. So we sent child to pediatric endocrinology department. There they found that child has developed grade 2 fatty liver with mild hepatomegaly. Also, his serum ACTH and cortisol levels were low. So a diagnosis of exogenous Cushing syndrome was made, and he was started on maintenance dose of hydrocortisone 3 milligrams and was advised to give a stress dose of hydrocortisone if child was to be taken for EUA or for surgery. Since we try to get genetic study of all our pediatric glaucoma patients, at the same time we got CS study report of this patient, and it was positive for USP11 gene mutation. On next follow-up, 3 months post-operatively, the weight started to decrease, moon phases started settling, and serum ACTH and cortisol level came down to normal values, and glaucoma was well controlled with IOP of 7.8 and 8.4 off medication with bilaterally clear cornea. This is a photograph of the last follow-up at 6 months post-operatively. We can see that child has attained the age-appropriate weight, moon phases has settled, and hirsutism was less, and glaucoma was within control at this point of time. Now let's have a pictorial comparison of post-operative course. Post-op day 1 when he was totally fine. At 1 month when he developed Cushing syndrome with a sudden gain in the weight. 3 month follow-up and last follow-up at 6 months. So the question here is, what went wrong for this child? The most probable cause could be the steroid overdose. So did we really overdose the child? We did our maths and we found that the dose we prescribed was within the safe limit. Also, since as already stated, the child had USP11 gene mutation as found on the CES. So another gene of the same family, USP8, has been implicated in Cushing syndrome by sustained upregulation of the EGF receptors. So there might be a genetic predisposition for this child which we might not know. So the most important thing in infant cases is to prevent the systemic absorption of topical eye drops. So every parent or caretaker has to explain about the punctal occlusion, just to press on the medial cancers for 10 seconds to prevent the systemic absorption of the drops. And we have to be vigilant in all these babies. If corticosteroid is to be used, it has to be proper dosed, and close monitoring is very important in these infant cases. Thank you.
That's an interesting case. Can you get a fatty liver in 3 weeks' time?
So it was there on.
I know it was there, but we did not check before this. Right? So I'm just asking: is it how quickly can fatty liver develop at that to grade 2?
Actually, I cannot say that, but it was reported by the pediatric endocrinology department that child had.
I agree that it was reported, but when you say this has to be a diagnosis of exclusion.
Yes, sir.
Because
There were some changes in ultrasound which they have noted. So
now, what he's trying to ask is, could you attribute the eye drops to cause so much of problem in such a short duration of time?
actually, this was one of
Is it
the
yes or no answer?
This is the rare cases. So there might be genetic predisposition which led to this rapid effect on the child.
How common is an acute this kind of
This was the
Cushing's
rare. This was the
developing?
rare case which we encountered.
Any other reports which you have searched in literature?
Just few. I think just one report that was for the sustained use of steroid, not for this short duration. So the only difference was that there is genetic predisposition which we found out.
Thank you.